and then sleep deprivation and stress. Okay, so this is a framework for why blood pressure can be elevated in the inpatient setting. Next slide. So now I want to transition to a little bit of the literature on how often antihypertensive medications are perhaps changed. And I want to first focus on discharge. This is data from Tim Anderson. He looked at veteran data from the VHA, veterans 65 years or older with a diagnosis of hypertension who were hospitalized for non-cardiac reason. Okay, and what you're seeing here is the rate of intensification at discharge based on the inpatient blood pressure levels, elevated, not elevated, moderately elevated, severely elevated. And then they also looked at their outpatient measures before hospitalization to get a sense if they were usually controlled or not controlled. Okay, and two things you see here is one is the probability of intensification was strongly associated with the inpatient readings, which makes sense. But if you look at the severely elevated group, how well they were controlled as an outpatient wasn't strongly associated with intensification at discharge. Okay, next slide. Another elegant aspect of Tim's paper is he looked at the intensification rates by groups of patients that may have a lower likelihood of benefit on the left, categories of life expectancy with or without dementia, metastatic malignancy, and we can argue about what the determinations of lower or higher likelihood of benefit. Higher likely to benefit on the right, conditions like MI, CHF, renal disease, etc. And what you see is a similar intensification rate. So Tim's in this paper makes the point that amongst people who may be less likely to benefit are still getting intensified at the same rate, and people who may be even more likely to benefit, who have high, perhaps, risk of ASCVD, have the same intensification rates. Next slide. Now, Tim took this one step further and looked at outcomes. Again, in an observational design, this was a propensity matched analysis, and he compared hospital readmission, serious adverse events, cardiovascular disease events between these patients, matched patients who were intensified at discharge versus not intensified. And the surprising finding here was that among patients that had their antihypertensive medication regimen intensified at discharge compared to what their home regimen was, had a higher rate of adverse events, readmission, serious adverse events, and cardiovascular events, okay? So this is some of the data when people make the argument that maybe it's better to not tune up or change or intensify antihypertensive medications. This is some of the data, and again, this is observational. Next slide. Another component that we pointed out was what are some of the steps to consider at discharge? And we organized this basically into two: careful review and careful adjustment of the antihypertensive medication regimen. Again, there's not good evidence around what the risk benefit of doing this is. There's the analysis from Tim, which shows it may not be ideal, but we're not sure in which patients. So next slide. To help with thinking through the transition from hospital to home, we created this figure. We call it AIM as an algorithm, A for arrange, comprehensive follow-up care within 2 weeks of discharge for assessment and confirmation of the diagnosis if it happens to be a new diagnosis, as well as management of medications and so forth. Inform, I for inform patients and caregivers about the importance of blood pressure and steps to take it home, including non-pharmacologic interventions, and then monitor. Of course, encouraging home BP monitoring and trying to facilitate patients getting into programs with team-based care. Okay, I appreciate these aren't available as much as we'd like, but to really try to help patients get into centers like that. Next slide. We also talked about medication counseling at discharge. 1 in 7 patients experience confusion about their medications at discharge, which does likely increase readmission risk. So highlighting the importance of clear communication about changes during admission and outpatient blood pressure monitoring, patient education, and again, ensuring community of care. So these are some of the frameworks that motivated this AIM arrange, inform, monitor algorithm. Next slide. Another area, again, is thinking about the pharmaceutical care or the antihypertensive medication regimen at discharge. Again, assessing the whole medication regimen, not just the antihypertensive medications, looking for drug-drug interactions. Trying to assess the quality of the antihypertensive medication regimen. I'll show some data on this in a minute. Of course, new medication initiation should align with the 2017, the most recent U.S. guidelines, single pill combinations, home monitoring, and team-based care. Next slide. Okay, in terms of gaps in quality of pharmaceutical care and hypertension, I just want to point out a few. This is data from our group that was led by Katie Darrington, showing new treatment of hypertension based on blood pressure level. And we found that about 60% of veterans with a pre-treatment blood systolic of greater than 160 were started on only single agent. So this is a significant gap in care. We know that most patients with hypertension need 2 or 3, and that initial combination therapy is more effective at achieving BP control than usual care or step care. Next slide. Another quality gap that we've looked at is beta blocker therapy among people without compelling indications, such as coronary disease, heart failure with reduced ejection fraction, or atrial fibrillation. This is showing the prevalence of beta blocker use among veterans without compelling indications. And you can see in the most recent years, it's hovering around 20%. So this is another kind of quality gap that could be assessed in the hospital. Next slide. Resistant hypertension. Next slide. This was data Aisha Langford led in Jackson Heart Study, looking at the prevalence of the long-acting, more potent diuretics, indapamide, chlorothalidone, and the recommended fourth-line medication in resistant hypertension, mineralocorticoid receptor antagonists, spironolactone and eplerenone, and found that only about 7% of patients in the Jackson Heart Study with resistant hypertension were taking chlorothalidone and indapamide, and then only 17% were taking spiro or eplerenone. Next slide. Again, another quality gap that I think can be evaluated and taken advantage of the resources in the hospital. Another quality gap is looking at meds that increase blood pressure. This is, again, a paper from Tim Anderson using NHANES data, found that about 20% of patients with hypertension were taking at least one drug that can increase blood pressure. It's usually antidepressants or NSAIDs. Antidepressants are probably a little more tricky to modify, but NSAIDs are something we can help with. Next slide. Adherence. Critical to study more interventions that can actually help patients with adherence. This is another paper from Tim's group looking at hospital discharge, what the persistence rates were of new medications or dose increases or continuations. And just like all the other analysis, it's very low at 1 year, about 50%. Next slide. And then in the interest of time, I'll skip through these next couple slides and just go right to my gaps and future directions. It's about 2 more. I just was talking a little bit about the FDCs and team-based care. So we'll go back 1 slide. The key knowledge gaps are addressing the impact of inaccurate blood pressure measurement. Should we be modifying medications in the antihypertensive medications in the hospital or not in the absence of new or worsening target organ damage? And then what are the BP goals for inpatients? Those are 3 knowledge gaps. And then next slide. Future directions, team-based care, testing strategies to facilitate patient enrollment into team-based care from the hospital to home, home monitoring, evaluating approaches to ensure patients are discharged with validated BP, home BP monitors and training, what level of pharmaceutical care should be provided at discharge, what provides a favorable risk-benefit profile, and then therapy escalation thresholds. So with that, thank you very much.
Thank you, Adam. A fantastic presentation, as always. For the discussion, Bev, maybe all of the speakers from the session can turn on their cameras. Okay, great. And please, if people have questions or comments, please put them in the chat. Bev, would you like to get us started?
Yeah, I thought of a couple things. One was about measuring blood pressure. We got some questions on that in people that are overweight. And there was one question about using the forearm and also wrist monitors. Can that be useful for people that are otherwise hard to fit in upper arm monitors?
Do you want me
that's
to?
for Richard.
Yeah, sure. Thanks, Bev. Well, the default in most of the guidelines is to put a standard upper arm cuff, whatever that may be, 14 centimeters or so, on a forearm. I know of no, and then measure the radial pulse, radial pressure by either auscultation or palpation. Most of the guidelines have either been tenuous or at least careful that the use of present wrist devices, etc., need further evaluation. So I don't want to dip into that because I know that's coming up as a full discussion. But I think that one of the concerns I have about this is that the forearms in some people are remarkably large. They're also truncoconal in shape. And in fact, if you try to get to their wrists, it's very tight because they have a very pudgy forearm and a pudgy hand. So I'm not sure how accurate that is. I don't otherwise have a good answer for this. I'm simply reflecting what is principally my knowledge of what's in the literature. And the fact is we already know that all of these cuffless and cuff devices for arms and for forearms and wrists and fingers are out there. But there is still a great deal of information that we didn't know about their accuracy, their recalibration, etc. So I think that's the best answer I can give.
Yeah, and we've had some comments about children with large arms as well being very, very difficult and needing more research. Anybody else want to chime in? I have another question. Go ahead.
Another question about obesity, which is with major weight loss, is blood pressure measurement a challenge with excess skin tissue? And, are we going to be seeing this as a problem coming up, given, the increasing GLP-1 use and people losing substantial weight?
That's a great question, and I don't know that I have not seen anything that has really addressed this. Much of the literature I've seen is worried about skin thickness, and we saw something earlier about use of clothing, whether that impacts on it. The real issue, I think, Paul, the best answer I can give is whether a cuff is adequate to the bladder width is to the arm circumference, number one. And number two is that it has compressibility that is symmetrical to the arm. Beyond that, I don't think that there's anything. I'm not seeing anything. Maybe somebody else on the panel has or others in the audience, but I've not seen anything that says, what do you do when the arm gets much smaller?
Thank you. Bev, I'll turn things back to you.
Okay, and I think for Dr. Biagioni, if I did that right, what's the single most important thing I'm a family physician, and I know that family physicians often don't intensify medications in people who are 75 and older because they're afraid they're going to fall. Of course, they should be doing the postural BP before they make that assumption, and also ask them about the symptoms. But what is the most important thing you might tell them once they've done those assessments of what to do, or or just not how to be generically worried about lowering older people's blood pressure who might get a benefit?
Well, thanks so much for the question. And I'm not going to, I mean, it can get complicated based on how severe the orthostatic hypotension is. But in most patients, that even if they have mild orthostatic hypotension, they should be, their hypertension needs to be treated like everybody else. But obviously very important to choose the right antihypertensives. We see, for example, that we're using, or physicians are using a lot of carvedilol, and of course that's an alpha blocker. And if you already have postural hypotension, we've done studies recently showing that that will increase the risk, and it's better to use other type of beta blockers. You know, example like that. I mean, attention to detail, and a lot of patients at that age might be on tamsulosin. Again, people forget that that's also an alpha blocker. So identifying factors that can aggravate hypotension that have nothing to do with good treatment for hypertension, that would be the first step. But in most patients, you can do both. Lou, I think, is commenting already on this question, saying that there's evidence that there's slow gradual treatment of an older adult might actually reduce orthostatic hypotension rather than worsen it. And I think that is correct, that he's done very nice studies showing that uncontrolled hypertension increases the risk of orthostatic hypotension, perhaps the mechanism that I mentioned, that with nocturnal diuresis and worsening of orthostatic hypotension. So it can be a complicated issue, but if you remove aggravating factors and you focus on the treatment of hypertension, in general, that is the best for the patient.
Thank you. You want to have another one, Paul?
I'm going to ask Adam a question because something he said at the end of his talk piqued my interest, and this is focused on what to do for blood pressure measurement post-discharge. And you mentioned home blood pressure monitoring. Do you think that should be do you think that is the best approach post-discharge? I've read some data that some severe hypertension, I guess, returns to normal post-discharge. But I'm not sure what your thoughts are about blood pressure measurement, both, I guess, for those with severe hypertension in the hospital, but then also post-discharge, whether there should be programs or how that best should be done.
Yeah, I think it's a great question, Paul. And I guess based on my understanding of the literature, I think it's an open question, and I think it's an area that could help reveal the degree to which the blood pressures are elevated in the hospital as a result of the acute physiological process or the stressors, and confirming if the blood pressures go down at home without any intervention, the degree to which kind of that is contributing, and could help confirm the hypothesis that on average, in general, we should be very conservative with intensifying or initiating medications in the hospital. I think it's a really interesting question. I think we would learn a lot from like an implementation study or an actual study that utilized home readings after hospitalizations to kind of see more of what happens.
Yeah, I might add that it would be great to have just, if in my perfect world, there would be an RPM program with pharmacists on discharge if anybody had blood pressure questions, to review all their meds and monitor it for that post hospitalization period, almost kind of like postpartum hypertension.
And thank you. There's a comment in the chat for Jordy, or a question. Do you think there's enough evidence to suggest some devices work differently in CK patients warranting them becoming a special population? And I'm going to just add on my own piece to this question. There are different degrees of kidney disease. So can you comment about this within the context of stage 3 versus more advanced kidney disease, if you don't mind?
Yeah, and then Tammy added another question too that I'm happy to answer. So I think it's worse, obviously, as kidney disease worsens, that you end up with worse kidney function, having more accelerated vascular stiffening and higher blood pressures on average in the population, which are really the factors that likely confound the way that the oscillometric device is able to calculate the readings. I think that we don't have enough evidence to even know whether they have to be a special population, to Tammy's question. The studies that have identified that devices are not valid in patients with CKD have issues and have violations to protocols. And so I've not seen one, to my knowledge, that has not violated a protocol or that has provided enough information in their publication to know that they didn't violate a protocol for a special population in CKD patients. And so it's not 100% clear, but it seems part of it could be that CKD patients tend to run hypertensive, and the more hypertensive you are, the less accurate a lot of these devices are, and that could be part of the issue as well, where no matter what you do, whatever subpopulation of CKD patients you capture, you're going to struggle to end up seeing substantial validity with the devices. I don't mean to be a nihilist in that regard. I hope I'm wrong, but there unfortunately isn't sufficient evidence to say for sure. In terms of Tammy's other question of whether there's potentially a population with CKD and mild to moderate proteinuria in whom intensive blood pressure lowering might reduce renal outcomes, yes. I think that it's very similar to what we end up seeing with the reduction of hyperfiltration just with using ACE inhibitors or ARBs, that in people who particularly have secondary FSGS, meaning where people have too much blood flow that's creating harm to the kidneys, that you would see that renal benefit from blood pressure lowering in those patients. Anecdotally, we definitely see that. There's not been a large scale trial that has looked at this, unfortunately, but we generally, as a group of nephrologists, tend to agree that there is kidney benefit in certain patients with blood pressure lowering, and then in everybody else, there is definitely cardiovascular benefit, whether or not it makes their creatinine look worse.
Jordy, as a follow-up to that, I think one of the adverse events we've seen in some of the intensified medication trials going down to 120 systolic is acute renal issues. And you said some very interesting things to me about it, about whether we should be concerned about that or not as we go to these lower targets.
Yeah, there were several really elegant studies done post-hoc in SPRINT in particular, where they looked at tubular biomarkers in patients who had intensive blood pressure lowering. And basically the conclusion was that most of it is hemodynamic. Most of it is what I was starting to allude to in the talk, where when your blood pressures are higher, you're perfusing your kidneys more. And when you take away that extra perfusion, you're basically unmasking true kidney function. Or you may see